Good afternoon to everybody. So there is no conflict of interest to disclose. Our clinical case is a very long history that it has a duration of 51 years, and it started in 1965 with a right nephrectomy, and it ended 51 years later. So the patient was a 64-year-old lady with a remote right nephrectomy that was referred for resistant hypertension in 2006. So the nephrectomy was performed for massive hydronephrosis and recurrent infection when she was 23 years old. Her clinical history, so she was referred for so-called drug-resistant hypertension while on atenolol and manidipine. She had no symptoms, unremarkable medical history except for iodine contrast medium allergy and for the nephrectomy. And she had a recent detection of 50% stenosis of the left renal artery at ultrasound. At physical exam, she had very high blood pressure values, 211 over 87 millimeters of mercury, and she had a harsh 3/6 ejection breath at the base of the heart, so at the air point, and a systodiastolic breath all over the abdomen. Her blood tests were unremarkable. I would like to highlight that she had a normal renal function, and she had a normal potassium. And so was this really truly a resistant hypertension? And as you know, all of you know, the major scientific societies' recommendation for resistant hypertension diagnosis advise to call a resistant hypertension a patient who is not at target on 3 medications, and one of these has to be a diuretic or should be a diuretic based on the AHA hypertension guidelines. As suggested by the ASH guidelines, appropriate lifestyle should be implemented. So going back to the patient, this was her EKG that is pretty remarkable, but her transthoracic echocardiography showed left ventricular mass index increase, so left ventricular hypertrophy with a normal end-diastolic volume and ejection fraction, and an increased relative wall thickness, so it was an concentric hypertrophy. She showed also kidney damage. She had an increased urinary albumin excretion of 325 milligrams per gram of creatinine. So what would you do? What else would you like to know? And how would you treat her? So medical therapy or left renal artery angioplasty or stenting?
I would maybe try to check drug adherence.
Yes, this is a very good suggestion because it is very important to check for that, and because we know that.
I would not go easily for angioplasty stenting with only a 50% stenosis also.
I definitely concur. Angioplasty is not warranted in this case, and I concur. Nowadays, we should check for adherence in all patients with so-called resistant hypertension before giving them, calling them resistant.
Was this lady a smoker?
No, she was not.
And did she have peripheral vascular disease or signs of peripheral vascular disease?
No, no other signs of peripheral vascular disease.
But if you put things together, she has a so it's only one kidney.
Yes.
She has a deteriorated renal function and high blood pressure. So she should have renal artery stenosis as probably shown on the echo, but you have to be sure by other diagnostic that that is the case, and probably her high blood pressure may be associated with heart failure, as seen in one kidney with a stenosis. Having said that, I wonder what the cause of the bruit was on her heart. You didn't show it on the echo of the. What did you see? Abnormalities of her aortic valve?
She did not have stenosis. She had thickened aortic valve. So she had aortic sclerosis, but no stenosis. And she had a normal renal function. So her renal function was...
Maybe because we're coming from the same clinic, I have a question in the same line. This patient has a one kidney, one clip situation, and that would lead to very high blood pressure and deteriorating renal function. Still, she is very hypertensive in the face, for instance, of using atenolol. Did you consider the possibility of a pheochromocytoma?
Yes, she was screened for that, and 24 hours urinary metanephrines were negative.
Did you do a 24-hour blood pressure monitoring to confirm that this is not part of it, effect of white coat?
No, this was not a white coat effect. We did an ABPM, 24 hours ambulatory blood pressure monitoring, and it confirmed high blood pressure, systolic high blood pressure.
What was the size of the left kidney?
Actually, this is a good question. We can show it later. It was normal, though.
It was?
Normal.
Well, you would expect for someone to have had a single kidney for 20 years or something like, or 40 years actually, that the kidney will be hypertrophied.
Yes.
Having what you call normal size kidney suggests to me strongly that there is a stenosis, a functional stenosis. Otherwise, the kidney should have been well hypertrophied.
This is a possibility. So we went further with diagnostic studies.
Did you measure renin and aldosterone under standardized conditions?
No, because she was on. So when she when we saw her the first time, she was on atenolol, and she had really high blood pressure values. So we thought it was dangerous to try to keep her on washout, so on the calcium channel blockers and doxazosin to screen her. So it was on our point was that screening a patient with other drugs like hydrochlorothiazide or ACE inhibitors or ARBs, which will increase renin, will not give us reliable information in this case. And we thought it was dangerous to keep her on the two drugs.
But you could
we need to move on with the case, I'm afraid, so if we could have very brief comments. This lady has more secrets to reveal, I think.
Upon physical examination, were there any signs of volume overload, such as edema or hepatojugular reflux, for example?
No.
Because presumably, if that was the case and you correct the volume overload, her blood pressure would go down, but also her kidney function would deteriorate with this renal artery stenosis.
Yes, that is...
but no signs?
No.
Sharad Ratanji, Australia. Just two things. This patient is not yet drug resistant because you only got on 2 therapies. You don't have her on a diuretic.
I agree.
Secondly, the best treatment for her would be an ACE inhibitor. But before instituting that, would you consider doing a captable renogram to look at functional you know, whether the stenosis is functional or not, because with a captopril renogram, if you get the reduced perfusion, that will show that the stenosis may be functional, and you may be more careful about using an ACE inhibitor.
Okay, yes.
I think it's time to find out what you did do,
Yeah.
rather than what you might do.
Well, I definitely concur. So the attending physician increased the antihypertensive therapy, adding ramipril. However, he was worried about her renal function because she had only one kidney with a reportedly stenotic renal artery. And therefore, he ordered careful monitoring of the GFR, and her blood pressure values were thereafter adequately controlled, and the renal function remained normal with the medical therapy. And therefore, the lady did not show up for 3 years. So she showed up again in 2009. She verbally reported that she did an MR angiography, and her left renal artery stenosis was described as unchanged. A CT was unfeasible because of the allergy to the contrast medium. And then she did not present again until 2011. At that point, her blood pressure was high, very high, while on ramipril, and she presented with a renal Doppler ultrasound that showed an unchanged left renal artery stenosis of 50%, with a high resistivity index of the left kidney and a fistula involving the right renal artery. So a new MR angiography was ordered at that point. So the patient actually did not undergo actually underwent the MR, but did not show up for 5 years, and her physical exam was unchanged, still very high blood pressure, and this time she was on a very important medical therapy. She was on atenolol, lercanidipine, hydrochlorothiazide, amiloride, and valsartan. And here you can see a pseudolucensis sign. You can see that the high pulse pressure of the patient should here, you can see it here, so you can see the carotid pulse of the patient. The MR angiography showed, actually the report of the MR angiography reported a right arterial stump, 7 millimeters of diameter, connected through a large arteriovenous fistula, 40 millimeters, to the inferior vena cava. But the MR angiography images were still unavailable. So what would you do?
Any suggestions?
Okay.
Would anybody like to test her allergy to contrast?
To bring the CD with the images.
One possibility is to consider reimplantation of the kidney to the aorta.
Reimplantation?
Surgery.
Surgery.
Surgery to reimplant the kidney into the aorta.
Mm-hmm.
Okay.
Yeah, to make a bypass, I think that's what he means. Okay, well, I think the previous discussant meant to make a bypass of the left renal artery, but...
Why?
Why? Okay.
Oh, sorry, I mean...
That's not my question. What should I do, it was your question, and I would give her loop diuretics, because she has a decreased renal function, you're using... No?
No, she did not.
Okay, I seem to... have that in my mind, but well, then the issue is not a loop diuretic. Yeah.
A few years ago, there was a study on the ROX coupler, which was an artificial fistula between the arteriole and the vein,
yes,
resulting in a drop in blood pressure.
Yes.
In fact, this is a natural variant of the Roxcoppler, I guess.
Yes.
So please explain me, why is the blood pressure so high?
Not very successful. Not very successful AV fistula in this case.
But why is she hypertensive? I don't understand that.
Well, now maybe we will talk later about physiopathology. So
can I make just one comment on
this?
Yes.
Yes.
You showed a treatment that she was supposed to do with 7 pills a day, if I counted correctly. My question is, I would probably bring her in the hospital and try to give her the drugs under control one way or another. Because for a patient that does not show up for 5 years, does not show up for 3 years, does not show up for 3 years, I think the likelihood that she takes nothing or very little of what you prescribe, I think is probably 1 chance on 2. So I would probably do that before anything else, since it's quite a difficult situation for the kidney, and of course we could do any operations or whatever, but be sure that she takes what you prescribe.
Yes, I concur. As we mentioned before, like resistant hypertensive patients, and 30% of so-called resistant hypertensive patients are actually not adherent. So, very good comment.
Okay, could I make additional, more sort of technological comment? I am surprised that in fantastic academic center in Italy, you need to bring your MRI on a CD. I thought that we are progressing with precision medicine and digital radiology across Europe, and that these type of investigations are accessible to physicians, and we don't need to do what's happening in the United States, where the patient goes with his x-rays into the doctor because insurance company wouldn't share. So could Professor Rossi explain this to me?
Of course, Anna. Now we have all the radiological examinations in the system, so this issue is no longer there. But as you saw, this case lasted 51 years, and she had the first MR many years before, and moreover, she didn't want to come to Padua to have the test because she lived in the eastern part of Veneto region, and so she preferred to have her MR angiography done there, and she didn't bring the CD until she was pushed to bring it.
Okay, you're excused.
I didn't see her electrolytes in the last few visits, because I thought that in the first time she had 3.6 potassium, which is a little bit low. You said it's normal. What happens to the electrolytes during the follow-up?
The blood work was remarkable. It did not change significantly. You have anyway to take into account that, of course, she was on she was on hydrochlorothiazide, but then she was added. We added ARB, and we added amiloride, which is supposed to increase potassium. So it's not unexpected that potassium is still within normal range.
Can I make a proposal that we move to take
That's
a look
exactly what I was going to suggest.
To the MR angiography, because when I saw it, I was shocked.
So she brought her CD. At that point, she was on atenolol and lercanidipine because the valsartan had been withdrawn by her primary care physician for unknown reason. Again, blood pressure very high and physical exam that is unchanged. And so we took a look to the images of the MR. So this is the fistula that is very with a very huge diameter, 4 millimeters, and here you can see the other part of the fistula, and here you can see the inferior vena cava, and these are the images. Right renal artery, this is the fistula that has 2 parts, and then it drains into the inferior vena cava. So the reason why this happened is probably well, the radical nephrectomy. She underwent her radical nephrectomy, as we said, in 1965. So at that time, the surgeon clamped the renal artery and the renal vein together with a technique called artichoke technique. And this is the reason why she developed later AV fistula. So at this point, what would you do? Would you schedule a follow-up visit? Would you consult with a vascular surgeon, or would you consult with an interventional radiologist?
I think the answer is yes, so why don't we move along?
Okay. So we move forward. We consulted a vascular surgeon who gave an unequivocal indication to closure of the arteriovenous fistula because of the high risk of rupture with ensuing fatal hemorrhage. However, I thought the procedure was at very high risk, so we consulted the interventional radiologist who gave an indication to percutaneous embolization. So we admitted the patient on April 2016 to proceed with the percutaneous AV fistula embolization. But due to contrast medium allergy, the patient underwent prophylaxis according to guidelines with methylprednisolone, diphenhydramine, and ranitidine because it's required in the protocol of our hospital. But an anesthesiologist was present in the CT facility. So after the injection of the contrast medium for the CT, she underwent an anaphylactic reaction, and the patient was treated according to guidelines, and she had a swift recovery. And these are the images of the CT scan. And you can see here, this is the aorta, right renal artery, and this is the fistula here. And you can see the other part here. So at this point, what would you do? Would you do a conservative approach with medical therapy and follow-up, or an aggressive approach? New vascular surgery consult, or reschedule the patient for a new percutaneous procedure?
I don't think you're going to get any help from the audience, so why don't you tell us what you decided?
We rescheduled the patient for a new procedure. The patient recovered and was discharged in good health. However, she was very scared because she was now aware of the high risk of rupture of her arteriovenous fistula, but also of the high risk of the surgical correction. Moreover, she was scared of a new interventional procedure because of her allergy to the contrast medium. Therefore, she was scheduled again for the percutaneous procedure. However, we decided to exploit the use of carbon dioxide as a contrast medium. When we admit her again in October 2016, she had again high blood pressure on important medical therapy. The arteriovenous embolization procedure was performed in the angiography suite with anesthesiology support under local anesthesia. And these are the images. You can see here the renal artery. This is carbon dioxide. And you can see here the fistula, here. And then the interventional radiologist deployed Amplatzer device, 14 millimeters vascular plug Amplatzer device, and you can see here the angiography at the end of the procedure. This is the Amplatzer device, and the fistula is closed. So her blood pressure was at admission and at discharge was 125/75 millimeters of mercury. on the same therapy, atenolol, hydrochlorothiazide, amiloride, lercanidipine, and valsartan. After 1 month, she was still normotensive with lercanidipine and valsartan only. Few months later, we checked for the occlusion of the AV fistula that was confirmed at contrast-enhanced ultrasound, and her last visit, follow-up visit, was in January 2018. She was still normotensive on the same medical therapy. So any comment?
While you're coming to the microphone, this lady was initially diagnosed with left renal artery stenosis with an ultrasound and presumably Doppler. I can't imagine that a fistula like this could be missed at that time. She didn't have cardiac dilatation at that time, which you'd expect to see in somebody with volume overload like this. So what do you think has happened between her initial presentation many years ago and now?
What do you mean? Like why the blood pressure was uncontrolled
Yeah, I think
later?
there are two explanations. One is it was missed and it's gradually progressed. The other is that something's happened in the meantime to create a lesion like this. Anyway, I don't think we know the answer. Maybe we'll get some comments.
Well, it is difficult to say exactly what happened. Well, probably what happens is that the fistula is not fixed in time, so it progresses with time, and it increases in flow, and this affects the cardiovascular system. Despite we did not see LV dilatation later on.
Well, the only explanation I have to your question is perhaps the local hemodynamic changes after the closure perhaps made what was non-significant renal artery stenosis was, in retrospect, was a significant renal artery stenosis because of the flow that caused this flow to the remaining kidney. Otherwise, it's a miracle why, after this procedure, her blood pressure was well controlled. Instead of 7 medications, only 2 medications. So maybe local hemodynamic changes cured her.
In fact, if you look carefully at the very first image that you saw of the fistula, the aorta downstream, the fistula was like tortuous and funneling, consistent with this idea. The other explanation we had is that she developed nephrosclerosis in the remnant kidney, and 50% renal artery stenosis hemodynamically was totally irrelevant to that.
Just another hypothesis in accordance to what Professor Bernier asked earlier. Could it be that the patient started taking her pills after she had this intervention?
Well, yes, of course it is a possibility.
As I still don't understand why a Rox-coupler results in a blood pressure decrease, and this patients, we do exactly the opposite.
Well,
the blood pressure decrease.
We can go through the Rox-coupler later.
Along the same line, there is a lot of data from especially the surgical literature that when you clamp an AV fistula, there is an immediate rise in blood pressure. So why did you see any changes during the operation that could provide an extra argument that the fistula was indeed responsible?
Well, actually, the blood pressure dropped pretty quickly after the closure.
But what happened if when the AV fistula was clamped?
With the Amplatzer device?
With the blood pressure?
Yeah, what happened with the blood pressure? Yes, as I said, there was a decrease of blood pressure basically in something like
immediate.
10 not immediate, 10 minutes.
So how do you explain that in view of the literature that shows increases in blood pressure when you clamp the fistula?
Where did you see that?
If you
like that if you clamp a fistula, you will have an increase in blood pressure.
You have an increase in blood pressure. There's a lot of data from the surgical literature showing that.
Well, if you can see the data for. Okay.
Okay, just one hypothesis, an endocrine one. You didn't do hormonal examination, and I do not understand how we could not do it, even if the patient has an important hypertension. We try to do it, and there is something really important. Is there renin secreting remnants that could be related to the vascular, to the vessels that stayed in the organism? I mean, there is a part of the kidney that was in this, related to this fistula, and that could have been secreting renin for a long time, and it could be a renin-dependent hypertension. This is why, after excluding the lesion, the blood pressure dropped rapidly. This could be a hypothesis, but unfortunately, we don't have hormones.
Yeah, but unfortunately, if we did the hormones, they will be unreliable. So.
Petra Mala from Rome, congratulations. Did you control or did you remember the urinary excretion of albumin after treatment of fistula?
No.
No.
I'm sorry, but I have another point which puzzles me. We know from patients with AV fistulas, like patients with beriberi or Paget's disease, that they become volume overloaded. Now, you explicitly stated that this patient had no signs of volume overload. How do you explain this?
Maybe with our, well, it depends what do you mean for volume overload. If you mean that she did not have a left volume increase, she did not have a left volume increase, but she probably had a volume overload that was subclinical, probably.
But if you have experience with patients with beriberi, for instance, or other types of like Paget's disease, you always find some degree of edema.
Well, I think it depends, Peter, very much on the stage when you see the patients. And actually, this lady has a normal systolic function, as Dr. Maiolino pointed out. She had a normal ejection fraction. And it depends also very much on the size of the fistula. Obviously, she had a kind of hyperdynamic circulation, and eventually she would have undergone into high put heart failure. So that was another reason of concern. About the adherence to treatment, I think she was really adherent, and in fact we have a clue to that, and that is that in the EKG, she had bradycardia because she was on atenolol, okay? And with this type of hemodynamic picture, she should be expected to have tachycardia.
She certainly had a huge pulse pressure consistent with a significant AV anastomosis. Yes, final point.
One hypothesis could be a still of the fistula on the left kidney. When we see the left kidney on the CT, we observe a very small renal artery and with probably a ischemic renal left kidney.
Yes.
And when you close the fistula, there is a good perfusion on the left kidney.
This is of course a possibility. If there is a paper published by Kang in American Journal of Physiology in 2011 on a rodent model of AV fistula. And they demonstrated that basically, if you create a fistula, you will have a increase in compliance in the rodents that have a fistula, and an increase of blood flow, but you will have a decrease of renal blood flow with an increase of renal resistance. So this was published in 2011 in the American Journal of Physiology, and it was a group of Mayo Clinic.
Yes, thank you.
So it actually gives support to your theory.
Thank you. Would you like to finish your presentation
Yes.
now?
So our take-home messages are that guidelines do not always warrant a safe solution, and the use of carbon dioxide instead of iodine contrast dye is feasible in allergic patients, as secondary forms of hypertension should always be considered and ruled out before accepting a diagnosis of resistant hypertension. And AV fistula can go overlooked for years and result in target organ damage. And resistant hypertension can be due to an AV fistula, and its closure might resolve resistant hypertension. And is this consistent with the data from the literature? And of course, as you pointed out, it is not. It is not, because, as you pointed out, there is the ROX control hypertension study that was published on Lancet in 2015. This the device is the ROX coupler is a device that creates AV fistula between the iliac artery and iliac vein, and the conclusion of the authors are that the AV fistula is associated with a significantly reduced blood pressure. So these are the data, 6 months data. These were published on Lancet. So you can see here the change from baseline at office blood pressure, systolic, diastolic blood pressure reduced, and reduction also of the systolic and diastolic blood pressure at 24 hours ambulatory monitoring that was not seen in control patients. And here you can see the data at 12 months. Again, reduction at 24 hours ambulatory blood pressure monitoring of systolic and diastolic blood pressure. So there are some words of caution that we can give for the ROX control trials. Among others, there was no systematic screening for secondary hypertension of therapeutic adherence, and it was open label, no blinding, and no sham control group, which we know is pretty important in this interventional trial. And there was not very low rate of complication, and follow-up is short term. So you have to, all your consideration that came out in this discussion are appropriate, obviously. All your concerns are appropriate, but what we need to take into account that this ROX control trial has a 1-year follow-up, and maybe not, but maybe the difference is that our case is a 40 years old fistula, the effect of 48 years old of having an AV fistula. So the provocative last question is, I will refer my patient with drug-resistant hypertension for implanting an AV ROX coupler, or next time I will search for a high-flow arteriovenous fistula in my patient with resistant hypertension. And I thank you for your attention.
Thank you very much.